Welcome to today's webinar on Enhanced Recovery After Surgery, ERAS, Medical Education Engagement to Support Safe Prescribing for Surgical Patients. This webinar is sponsored by the White House Office of National Drug Control Policy with support from Enhanced Recovery After Surgery USA. For all listeners, your audio will be muted. This is Dr. Ronit Lev, Chief Medical Officer of the Office of National Drug Control Policy and Director of Operations of the Emergency Department at Scripps Mercy Hospital in San Diego. Thank you to our participants for joining our webinar today. We're very grateful for your time and interest in the subject. We have been asked, should we hold a webinar on enhanced recovery after surgery and safe prescribing during a pandemic? I can report from the front lines in the emergency department that the issues of addiction, safe prescribing, and surgical cases do not cease during a pandemic. Over the past week, I've intubated a patient with a fentanyl overdose, admitted a patient with a hot gallbladder that needed surgery, and treated an elderly woman who fell, most likely due to the combination of her pain, anxiety, and sleep medications. The coronavirus pandemic will come and go, but the issues of addiction, safe prescribing, and better medical care through ERAS will remain. Today's agenda will include a presentation by our experts, some video testimony, and moderated questions. We invite you to join the conversation on Twitter throughout this event using @ONDCP Twitter handle or any of the Twitter handles for our speakers' agencies. Joining us today is the Honorable James W. Carroll, Director of the White House Office of National Drug Control Policy in the Executive Office of the President. Director Carroll leads ONDCP's charge to coordinate drug policy across federal government. Prior to joining ONDCP, Director Carroll served as Assistant to the President and Deputy Chief of Staff at the White House. He has held various advisory positions in the executive branch of government and general counsel to the Ford Motor Company Fund, beginning his career as a state prosecutor in Virginia. I will be forever grateful to Director Carroll for bringing me on as a Chief Medical Officer. This is a reflection of his out-of-the-box thinking and bringing on various expertise to solve the nation's opioid epidemic and addiction crisis. Director Carroll is a very compassionate leader with heart and soul dedicated to the mission of saving lives. It is a pleasure to have Director Carroll endorse this webinar and the mission of enhanced recovery after surgery. It is also a pleasure and honor to have with us today Rear Admiral Sylvia Trent Adams, the Principal Deputy Assistant Secretary for Health. Rear Admiral Trent Adams shares a responsibility with Assistant Secretary for Health Admiral Brett Jawar in program priorities covering the full range of public health activities within the Office of Assistant Secretary for Health. She has served as Acting Surgeon General, Deputy Surgeon General, and as Chief Nurse Officer of the United States Public Health Service. I want to personally thank Rear Admiral Trent Adams and her team for cutting red tape in healthcare and bringing resources in an unprecedented manner that is helping us soldiers in the pandemic battlefield of the hospitals. Rear Admiral Trent Adams also supports safe prescribing and enhanced recovery after surgery and her work on the opioid epidemic and the crisis of addiction.
Briefly, I'll review some of the things that the director mentioned about the Office of National Drug Control Policy. This is a schematic of our agency that's under the Executive Office of the President. Next slide. ONDCP is charged with coordinating drug policy across the federal government with the budget oversight of the agencies that it involves. The President's 2020 budget includes a record $34.6 billion to address every aspect of the addiction crisis, more funding than ever before. Next slide. Our policy and funding is governed through the National Drug Control Strategy that is focused on prevention, treatment, and recovery, and reducing the availability of illicit drugs. Next slide. The director mentioned our historical national treatment plan, and this is the framework for everyone to bridge the addiction treatment gap, and invite everyone to look at that and see how each one of us can contribute their piece in making this a reality. Next slide. The need for addiction treatment is shown by the data from the National Survey on Drug Use and Health. In 2018, 21.2 million Americans needed treatment for a substance use disorder that included alcohol and drugs, and yet only 11.1% received specialty treatment. Next slide. As the director mentioned, our vision is to see in America where an emergency physician can diagnose appendicitis and refer a patient to a surgeon, and likewise diagnose a patient with a substance use disorder and make a consultation to an addiction specialist. How many surgeons, anesthesiologists, and nurses listening in today have treated necrotizing fasciitis or abscesses in a patient with substance use disorder? That patient received excellent surgical care, probably an infectious disease consultation, but did anyone address the underlying disease of addiction? To that effect, our office is working on expanding the addiction medicine workforce. Next slide. There's been a national alert on the volume of opioids prescribed by the medical community. This slide from IQVIA Institute shows the opioid prescriptions peaked in 2011 in terms of morphine milligram equivalents, or 72 pills per adult American. We must remember that there was a national push in the 1990s to address pain and to use opioids, and the medical community responded. Now we see the effect of the medical community uniting and responding to the opioid crisis. Since 2011, there has been a 43% decline in opioid volume, and 2018 saw the largest single-year decline in prescription opioids in history at 17%. Next slide. While opioid prescriptions have gone down, how has this correlated to mortality? Total opioid mortality for medications has been going up and up despite the hard work of the healthcare professionals. How could this be? The data looks at opioid mortality that excludes known illicit opioids, such as heroin, but it includes all opioids available by prescription. That is hydrocodone, methadone, and fentanyl. Fentanyl is included as a medication death, although we know that the overwhelming majority of people who die from fentanyl obtain it illicitly and not from the pharmacy. On the right, the circles show the division of opioid prescription, pseudo, synthetic opioids other than methadone, and the overlap of the two. And you see how the total number is driven by the red circle, pseudo, the fentanyl. The yellow bars in the graph represent prescription opioids that exclude any pseudo or fentanyl. This shows a rising peak in 2011, followed by a decline. The healthcare effort in curbing the opioid prescriptions has translated into decreased mortality due to prescription opioids that exclude pseudo or fentanyl. Next slide. That's the good news, but is it good enough? Let's look at mortality due to unintentional overdoses from all medications that exclude illicit drugs. Are we, the medical community, where we should be? This color graph shows the rise in all drug-related overdoses with a tragic annual increase. The red part of the graph shows unintentional medication-related overdoses that exclude pseudo or fentanyl. The red part of the graph is theoretically under the control of the healthcare community, our supply chain. In 1999, we were at 2 deaths per 100,000. We peaked in 2011, and in 2017, we see a decline at 4.7. We are improving, but we still have to do better. Next slide. This is a slide from a study in San Diego conducted looking at all accidental overdose deaths caused by medications, not illicit drugs. And the colors show the various medications. Opioids are number one, but benzodiazepines are a close second, and sleeping medications and stimulant medications are also a factor. As we educate about safe prescribing, we need to remember the central nervous system medications are additive in their effect, and we need to coordinate multiple prescriptions as multiple providers. Next slide. It is now my honor to introduce and hand over the presentation to Dr. Tonya Young-Fadok, colorectal surgeon at the Mayo Clinic in Arizona and past president of Enhanced Recovery After Surgery USA. She will talk to us about an overview of ERAS.
Thank you very much, Dr. Lev, for hosting us and for recognizing the role that ERAS principles might be able to play in the safe prescribing of post-operative narcotics. It's truly an honor to participate in this panel. And my role here is to give an overview of how ERAS can potentially help with the prevention aspect that you've mentioned in terms of reducing opioid use and prescribing for the surgical patient. Next slide, please. What is ERAS? Next slide, please. Stands for Enhanced Recovery After Surgery. The ERAS Society was founded by Professors Ole Lundqvist from Sweden and Professor Ken Fearon from Scotland in 2010. And the ERAS USA chapter was founded in 2016. What ERAS means is using evidence-based medicine to support the preoperative and intraoperative and postoperative practices that help our patients return to normal function after an operation. It requires a lot of teamwork because it involves coordination and understanding across multiple different disciplines, such as nursing, anesthesia, and surgery. It's also applicable to multiple different surgical specialties, for example, ranging from head and neck surgery to colorectal surgery and pretty much everything in between. When it's done in the best possible way, ERAS results in patients recovering more quickly, having less pain postoperatively, so they spend less time in the hospital, and it also reduces complications. The example graphs you see here show the marked decrease in patient function with standard care postoperatively and the slow return to normal function, and the lesser decrease in function in patients who are treated under an ERAS protocol. Next slide, please. And it's actually this faster return to normal function that forms the basis for the two arrows in the logos of both the ERAS Society and ERAS USA. Next slide, please. So where do we find all the evidence for this? It's actually dispersed all over the scientific literature in anesthesia, surgical, and nursing journals. But the ERAS Society has been central in bringing together all this evidence in published guidelines. The ERAS Society has convened panels of experts who pull together all this disparate evidence into sets of guidelines for different specialties. And then these international panels evaluate and weigh the quality of the evidence and also judge how strongly an item is recommended. The first published set of guidelines was for colon and rectal surgery back in 2013, and the Society is now responsible for 26 different guidelines for multiple surgical specialties, and all those guidelines are available for free to anyone at the website erassociety.org. Next slide, please. So here's an example of one of the earlier guidelines, and I don't anticipate anyone trying to read each of these items. I'm putting it up here to demonstrate that at first glance they look rather complicated. There are multiple items, and on these original guidelines you'll see that pain management is the fourth item from the bottom. Next slide, please. However, in terms of implementing enhanced recovery, it's helpful to group all these items into three main topics. One is maintaining the patient's physical and intestinal function. Another is keeping fluid balance correct. And third, what I actually personally consider the most important part, which is control. If the patient doesn't have pain after an operation, they don't behave like a patient. In other words, no pain, no patient. Next slide, please. But how can we minimize pain? And that's where I think the role of multimodal pain management comes in. This means using multiple complementary ways of minimizing pain. The ERAS guidelines strongly emphasize the impact of minimizing knock because they have such negative impact on the operative patient's recovery. They can cause respiratory depression, they can cause lack of return of bowel function, and a frequent side effect is nausea and vomiting, which prevents the patient from eating. After we attended several ERAS meetings in Europe, we realized that the European medical community wasn't seeing the same opioid epidemic that the US was. So far, there are many reasons for this complex issue, But when we founded ERAS USA in 2016, we realized we needed to make post-operative pain management a focus of our attention. There are numerous ways of helping with pain management and reducing the need for narcotics. And this starts even before the operation does, with patient education to help relieve anxiety of the unknown, and also using non-narcotic pain medications to block pain receptors ahead of the operation. In the operating room, we have multiple approaches for both anesthesiologists and the surgeons in terms of working together with teamwork and in terms of blocking pain receptors with infusions and different ways of delivering local anesthetics. Post-operatively, round-the-clock use of non-opioid pain medications and other interventions provide a background of pain control, and now we can just use narcotics for breakthrough pain. This has allowed significant reduction in the number of pain medications that are prescribed at discharge. I'd like to give an example of one component of this that we have found to be very helpful in our own practice, which is the slide, please. Over a period of 18 months, we attempted to learn more about abdominal wall. Developed a new, simple approach that has reduced narcotic use by 70% here, measured in terms of morphine milligram equivalents. And what I would like to do is share a simple video of most effective block with you. Next slide, and please would you play my video.
The right side of the abdomen has been marked to show the costal margin and iliac crest. Here is the laparoscopic setup. This is the laparoscopic needle, 20 milliliter syringe. The needle has a bevel on it to enable it to slide beneath the transversalis fascia. This is looking at the right upper quadrant, pressing beneath the costal margin in the anterior axillary line where a lap tap is done, mid-axillary line where an ultrasound tap would be. So you can see this is going to be more posterior, just above where the retroperitoneum starts to arise. That click indicates the needle slipping beneath the fascia. Now looking at the left upper quadrant, again pressing just beneath the costal margin to identify it. Needle is introduced and aiming for as far as possible before the retroperitoneum begins. Here, this is just beneath the peritoneum, immediately recognized, and then slid beneath the transversalis fascia. With injection, there is no welt, just slight swelling.
Thank you very much for allowing me to share that with you and for your attention. And it is now a pleasure to introduce my friend, colleague, and President-elect of ERAS USA, Dr. Michael Scott, who will in a anesthesiologist role in ERAS.
Thank you, Tonya. It's a real honor to present today, and my thoughts are with everyone in the audience today at difficult times. I'd like to give an overview of the anesthesia team and their role in the patient's surgical ERAS pathway, and in particular concentrate on how we can reduce the use of opioids during surgery, which in turn leads to the subsequent decrease in their use post-operatively. And if you're not discharged with opioid prescriptions, then you reduce your downstream addiction risk. Next slide, please. So an anesthesia team is made up of lots of different components. You'll be aware that there are attendings in anesthesiology, but there's also CRNAs that form the main backbone of our service, as well as if you're in a teaching hospital residence or trainees. But also the acute team are made up of a combination of these people. And what's interesting is a lot of people think anesthesiologists just put you to sleep and wake you up after, but in fact we have a role across the whole of the hospital, and we work in pre-assessment clinics, pre-surgical units, the operating rooms, and obviously in the immediate post-anesthesia care units, as well as we do all intensive care and look after you if you need support there. And also the pain team will visit you on the floor in the post-operative areas. Next slide, please. So you can see we're involved in key areas of your recovery. So pre-assessment and optimization, giving a good anaesthetic with residual side effects, and as well as that, delivering all the enhanced recovery elements that you need to get good recovery. And as Tonya said, that one of these which is key, is fluid therapy and blood pressure control. And the other is optimal opioid-sparing analgesia using nerve blocks and multimodal analgesia. And if you get all this right, you get a patient that can eat, drink and sleep and mobilise after surgery. And so, as Tonya said, you then have not really got a patient on your hands. But you've got to get all of these points together and get them all right. You need about 80% of all the elements to really get a good outcome to enable your patient to be able to do these things. Next slide, please. So in the pre-surgical clinic, no longer are we just passing people with heart disease. We've got 6 big ways that we can modify and improve your outcomes, even before you get to the hospital. We can treat anemia with IV iron infusions. We can control diabetes and glycemic control, your HbA1c. We can give nutritional supplements, particularly for patients with cancer. And very importantly, this is where our approach to opioid reduction starts. So there's ways that we can refer you to reduce your opioid need if you are taking opioid chronically. The elderly are also at risk of major surgery, so we can use frailty screening to improve their outcomes. And finally, we give you carbohydrate drinks to take the night before and morning of surgery to basically get you ready for your own marathon. So it's a bit like having a bowl of pasta before the marathon, which gives you something for your body to work on while you're asleep during surgery. Next slide, please. Give you some idea of what we do in the operating room as anaesthetists. We give everyone post-operative nausea and vomiting, or PONV prophylaxis. We give antibiotics to try and reduce the risk of wound infection. We control neuromuscular block and make sure that you're reversed adequately. And then we control your temperature using warming fluids and actually warming devices, as you can see. Next slide, please. We control the depth of anaesthesia, important in the elderly to reduce post-operative cognitive dysfunction. And we use short-acting anaesthetics in order to do that. We maintain your blood sugar control. And also, as I said, the 2 core elements of what we do are get your fluids and hemodynamics right and use opioid-sparing analgesia, epidurals and spinals and nerve blocks. You're going to see a lovely video from Steve Cates' team down at VCU of how we do these preoperatively before certain operations. As well as that, in the operating room, we have special infusions like lidocaine, dexmedetomidine, and ketamine. These are specialist drugs that help reduce opioids downstream so that when you wake up, you won't need any opioids for breakthrough pain. Next slide, please. So we're moving away from a pain score. Something that we published in Perioperative Medicine, this is the Perioperative Quality Improvement Group in the USA, is optimal analgesia after surgery is no longer a number. It's about making sure patients are optimized for comfort so that you can move and you can sleep, but also it's about fastest recovery, getting you eating, drinking, getting bladder and bowel function with the fewest side effects of those nasty things you get with opioids: delirium, respiratory depression, sedation, itis and nausea and bowel dysfunction, and dizziness and itching. And if you can do that, you basically get your patient drinking, eating, with good analgesia, mobilizing and sleeping, what we like to call a post-operative dreams. Next slide, please. So really, the backbone to achieving opioid-sparing analgesia is getting the right analgesic framework for each patient and the type of operation. So orthopedics is very different from something like abdominal surgery from thoracic surgery. But the backbone of multimodal analgesia is acetaminophen, non-steroidal anti-inflammatory agents, gabapentinoids, and then some sort of central or regional nerve block using local anesthetics, just like you've seen in the video with Tonya's with the tap block. And then we limit opioids to breakthrough pain or when other alternatives are not available. Next slide, please. So to visualize this is a way that we deliver optimal analgesia with opioid reduction. And the time base is going from the left to the right with preoperative clinics through the operation in the middle through to discharge home. And you can see in the green here, the mandatory general principles are all about educating patients and setting realistic patient expectations and the fact that they won't have a pain score of 0. It's all about actually going now towards functional recovery. And this has to be reinforced all the way through the patient pathway. Following down, you can see in blue, non-steroidals, anti-inflammatories, and gabapentinoids start preoperatively and are maintained through the perioperative period and into the discharge home. Then we've got local anesthetic techniques, single shot or continuous catheter techniques in purple, and those are then tailored off in the post-operative care unit or after the first 1 or 2 days after surgery, depending on the type of surgery. And then there's the other special adjuncts that only anesthesiologists give, like dexamethasone and ketamine. But the other key thing is that every hospital needs a rescue plan for suboptimal analgesia, which doesn't just mean we give lots and lots of opioids. And that's where your pain team really come into their own, because they're experts in managing pain and breakthrough pain and can reduce the amount of opioids you get using other techniques. So I hope I've given you an overview and summary of how the anesthesiology team can reduce your opioid need during surgery, and which means you don't go home on many opioids, which means you're less likely to get addicted to opioids downstream. Next slide, please. So next I'd like to introduce Dr. Liza Wick. She's a colorectal surgeon and ERAS champion. She's a professor of surgery at the University of California in San Francisco. But she also was awarded the HRQ grant while she was at Johns Hopkins for ERAS implementation across the whole of the USA as part of the American College of Surgeons. So I hand you over to Liza Wick.
Thank you so much, Mike, and thank you for inviting me to be part of this webinar. I'm really honored to be here. Next slide. I was asked to speak about enhanced recovery from the surgeon's perspective with a particular lens on ERAS as a tool to reduce opioid exposure, and I just thought I'd highlight from my experience and then what we've learned through the national project as well. So I think ERAS has been a really powerful tool to help accelerate the approach of partnering with patients and families as they undergo surgery, particularly around pain management. This has allowed us to set expectations about how much pain to have after surgery, they'll have after surgery, the efficacy of non-opioid analgesia, and really allowed structured patient interactions that are part of these ERAS pathways. And for me, that's been a tremendous thing, and for my colleagues as well. Furthermore, I think ERAS has brought forward really the value of promoting non-opioid analgesia and thinking about that as a first-line analgesic agent, both in the operating room, even before the operating room with preemptive analgesia, and then in the recovery and discharge. And finally, ERAS has been about pathways and getting consensus at our hospital and reducing variation. So whether that's about what antibiotic we use or what our pain management regimen is, this movement to reduce variation and standardized care has really accelerated progress in this area. Next slide. So like Mike mentioned, I've been helping to lead a national collaborative around ERAS implementation. It's funded and guided by the Agency for Healthcare Research and Quality. It's a collaboration between the Armstrong Institute for Patient Safety and Quality at Johns Hopkins and the American College of Surgeons. And the project is 6 years in length, and the goal is to support hospitals in adopting enhanced recovery principles at their hospital for a subset of surgeries. And the program is really founded on how we do this work, how we actually implement it at the hospital so that we have an effective, sustained program at the hospital and really meaningfully improve patient outcomes. And as the program has evolved, in addition to the traditional surgical outcomes we were charged with improving, we've also recognized the importance of reducing opioid exposure and reducing new persistent opioid use in surgical patients. Next slide. So again, hospitals that participate in the program, they participate for about 18 months, and the goal of their participation is that they develop a pathway that includes all the principles of ERAS as well as best practices for multimodal analgesia and opioid-sparing approaches for surgery. This is implemented by a multidisciplinary team, and it's really evidence-based. And we really emphasize and we help people work through the process of coming up with a consensus at their hospital and an effective implementation that will be sustained long after their participation in the program. So it's been an exciting project. We have over 295 hospitals participating. Folks have worked through this kind of work in colorectal, gynecology, orthopedics, and our last group is focusing on emergency general surgery. Next slide. Well, it's too early to tell the impact of the program. We do know from the data collected that early results show that we're improving the use of multimodal analgesia, reducing the hospital stay for patients undergoing these procedures. And for the bowel surgery, we've seen accelerated return of bowel function after intestinal surgery, suggesting that indeed we really are reducing opioid exposure. So our hospitals are still joining and working. Hopefully we'll be able to pick up our intense work once the pandemic wanes, but the final results will be available in 2022. And again, I just want to thank you for inviting me to join this webinar and share the work we're doing. And with that, I would like to turn it over and introduce Dr. Stephen Cates, an orthopedic surgeon with the American Academy of Orthopedic Surgeons, who will talk about orthopedic surgery in ERAS.
Thank you. Next slide, please. I'd like to thank Ranit and the ONDCP for inviting me to participate here. So I'm also supported by the Agency for Healthcare Research and Quality grant that Liza is the principal investigator of, and I'd like to thank AHRQ as well. Next slide, please. The enhanced recovery after surgery process offers a number of areas to refine orthopedics. So basically, we're improving by having standardized preoperative processes. As Mike said, the improved anesthesia preoperative planning, the improved intraoperative anesthetic management, improved emphasis on nerve blocks and regional anesthesia, reduced postoperative pain, and reduction in opioid medications postoperatively and at discharge. Next slide, please. To do this, part of the process is to optimize the patient for elective surgery. If they have diabetes, we want to get their hemoglobin A1C to be less than 7.5. We want to correct anemia so the patient won't require a transfusion and gets through the surgery with less risk of a complication. Smoking cessation is very important, and we try to stop smoking 4 weeks preoperatively. It improves wound healing and reduces all complications. And then we either stop or wean down opioid use to less than 60 morphine equivalents pre-op. Unfortunately, many of the patients are taking large doses of opioids, as Director Carroll and others have stated, and this is a major problem. So we actually put a strong, hard stop on surgery, so the patients have to wean down or stop the opioids altogether in order to get elective surgery performed. For weight control, we also try to get the patients to lose weight so that their body mass index is less than 40. Next slide, please. Preoperative education is critical. We prescribe preoperative exercise or prehab so the patient is fit for surgery. Preoperative education, and this is often classes, plus the education we do at the office visits to make them smart for surgery. We decolonize the skin to prevent infections, and we use chlorhexidine washes and wipes for that. We do carbohydrate loading with a carbohydrate-rich drink prior to surgery so the patient isn't fasting entirely, and the patient additionally is hydrated before they have surgery. And then our discharge planning is done ahead of schedule surgery so that we can facilitate a short length of hospital stay. Next slide, please. During the surgery, we try to minimize harm to the patient. We try to minimize blood loss. We use tranexamic acid to reduce blood loss, which is a very inexpensive and effective medicine that was developed for another purpose but works well to prevent blood loss during surgery. Regional anesthesia, as Mike Scott said, is extremely important. Here is a patient getting a spinal anesthetic by one of our anesthesiologists, and she was pain-free with her surgery. We also use regional nerve blocks to reduce the postoperative pain. Fluid optimization is essential, as Mike said, so we maintain that ideal volume status and helps the patient recover nicely from the surgery, both at the big level and also at the level of their cells in the body. And multimodal pain relief, as everyone has mentioned, to avoid opioids. Next slide, please. Postoperatively, we do immediate ambulation as soon as the spinal has worn off. We use nerve blocks for pain control, and we use we have seen a dramatic reduction in delirium or postoperative cognitive dysfunction. Next slide. These are our actual data from my hospital showing that the opiate pill count has dramatically reduced just over 3 years when implementing this program. So you can see with the graph here that in 2018 we were prescribing more than 2019 and then even less in 2020. And these are for major surgeries for hip and knee replacement. Next slide, please. Also, with appropriate ERAS protocols, we've dramatically reduced acute kidney injury. And although we didn't have an enormous number of such cases, we have really reduced the number down dramatically. And these are the acute kidney injury cases, stage 1 and stage 2, which the patient probably doesn't even realize they've had, but we can see it with laboratory values. And you see we have no severe kidney injury requiring dialysis. Next slide, please. We've also seen a reduction in mortality with the ERAS program, and we don't like to think that someone could die after an elective surgery, but the reality is that is a possibility. So with a very thoughtful approach in managing their medical conditions more tightly, we see reduction in mortality. Next slide. And we've reduced the hospital length of stay. It was pretty stable for 2017 and 2018, a little bit less in 2019, but we've dramatically dropped it down to just over a day in the current fiscal year, which is July to July. So we're almost at the outpatient level for these hip and knee replacements with length of stay. And this is directly related to the Enhanced Recovery After Surgery program. Next slide. So this is a team effort to implement. So it requires implementation science. It requires champions such as Dr. Scott and myself. Senior leadership has to buy into this, like our chief executive officer and all the other chief officers of the health system have supported this program. All of the surgical department chairs, the anesthesia leaders, our quality team, the nurses, and then our IT department had to help us fix every single electronic order set. And the residency program directors have supported the program as part of the teaching effort for the house staff, so they learn this program at a teaching hospital such as ours to go out and practice that way for their next 30 or 40 years. Next slide, please. So thanks very much for your attention, and I'd like to show you a video where a couple of patients are going through the program, and these are actual patients. They're not actors, and so it might be helpful for you.
Enhanced recovery after surgery is a fundamental remapping of the way that our patients and providers interact with one another regarding the surgical experience. It's really about engaging the patients in a way that help them understand the role that they play in the surgical process, taking things that are meaningful about our health and wellness and applying those in the surgical setting. Our patients are the most important thing to us, and what we want is for them to have a surgical experience where they come out feeling better than they did before the surgery.
Meet Susan Stein, who comes to VCU Health System for bilateral hip replacement surgery.
So I'm going to ask a lot of questions today.
This morning, Susan will meet with different members of the medical team who will assess her readiness for surgery, address risk factors,
your hemoglobin, hematocrit were all fine, you're not anemic.
And prepare a plan to optimize her health before her surgery. Once the plan is set, the provider teaches Susan about the things she will need to do in the days leading up to surgery. Susan will use an incentive spirometer to improve her lung function and determine what her breathing goals should be after surgery. She will be instructed on a 5-day decolonization regimen that aids in the prevention of a surgical site infection. And she will receive a special carbohydrate drink mix to provide her body with fuel for the surgery and ensure she's not dehydrated. Susan leaves the PACE clinic with all the instructions and supplies she needs to arrive fit and ready on the morning of surgery. Meet Mr. Frank Elliott, who comes to the VCU Health System for total right knee replacement surgery. He had his left knee replaced successfully using the ERAS protocol at VCU 3 months ago, and he's chosen to have his right knee replaced using the same approach. Mr. Elliott is getting prepared for surgery in the preoperative area. He will receive some of the medications used for our multimodal preemptive pain management approach.
So 975 milligrams of Tylenol, 300 milligrams of gabapentin, and 200 of Celebrex. And the purpose of giving you all 3 of those beforehand is to just help with pain afterwards and hopefully limit the amount of opioids we're giving you and get you out of bed sooner. Okay?
He has been allowed to consume a clear carbohydrate-rich fluid up until 2 hours prior to surgery. Next, Mr. Elliott meets with an anesthesia team member to discuss the regional anesthesia he will receive. Regional anesthesia is strongly preferred with the ERAS protocol. This typically includes a spinal or combined spinal epidural anesthetic and may include a nerve block in the thigh above the knee replacement site to dramatically lessen postoperative pain. In the operating room, Mr. Elliott will rest on a comfortable operating table with a spinal anesthetic, oxygen, and appropriate anesthesia monitoring for blood pressure, oxygen level, and temperature. He will receive sedation if needed. Once Mr. Elliott is fully prepped and draped for the surgery and in final position, the surgery is performed with the use of a tourniquet to reduce bleeding. The procedure will take approximately 1 hour. In the recovery room, Mr. Elliott is monitored and we allow the spinal anesthetic to wear off. He is awake, alert, and comfortable, and is even allowed to have a protein shake for nourishment. On the orthopedic floor, Mr. Elliott is receiving appropriate multimodal pain medicine, and he will walk with a walker a short distance several hours after the surgery was completed.
Lots of pain?
Okay.
This has been shown to expedite progress and reduce complications associated with bed rest. We are now on the first post-operative day, and Mr. Elliott has undergone physical therapy.
Good job.
And he has been found to be safe for discharge. He has been instructed to take Tylenol every 6 to 8 hours for the first week after surgery, and is given a limited number of pain pills to take only if needed for breakthrough pain. He will go home with limited home care services for recovery, and will follow up in clinic with Dr. Cates in 2 weeks.
Enhanced Recovery After Surgery, or ERAS in shorthand, is an international initiative to improve perioperative care and continuity of care for surgical patients. We at VCU are at the forefront of that initiative, and it's resulted in superior patient outcomes as well as enhanced patient satisfaction. We're very proud of the work that we're doing here at VCU, leading the way in such an important initiative as ERAS.
So very good. Thank you. And next slide, please. And I'd like to introduce my colleague Desiree Chappell, who is a nurse anesthetist, and she is going to speak to you next. Thank you very much.
Well, thank you so much, Steve, and thank you, Dr. Lev, and to the ONDCP for the honor to present during this very important webinar. My name is Desiree Chappell. I am a CRNA, or a Certified Registered Nurse Anesthetist. I'm also the host of Top Med Talk, a free, global, perioperative medicine daily podcast. I'm on the board of directors for ACER, and I'm a director for the Evidence-Based Perioperative Medicine, or EBPOM USA. Now, I live and work in Louisville, Kentucky, an area of the country that's been particularly hit hard by the opioid crisis. And it's through my work to help lead an ERAS program with the medical director of our anesthesia group and our hospital ERAS coordinator and the entire ERAS team that we personally contributed to the reduction of opioids for the surgical population within the Commonwealth of Kentucky. Slide, please. Next slide, please. I say this was all done with my colleagues because ERAS is a team sport. And as the other speakers alluded to, it is not something that one person themselves can implement and sustain. A multidisciplinary team, or a team made of healthcare providers from all different backgrounds, lead and execute enhanced recovery programs. This is a positive aspect, but sometimes can be a challenge for everyone involved. Traditionally, medicine, as you probably know, has worked in silos. You know, there are inherent difficulties with overlapping care. For example, when it comes to budgets, this is a perfect example. Surgical services and pharmacy each have their own cost buckets, hence siloed from working with each other. Now, they may have a reduction in one area, but increase the cost in another. And for the hospital, it's an overall savings, but difficult to reconcile the cost buckets bottom line. By forming multidisciplinary teams, the representatives from all of these different silos come together, transcend this fractured care, and deliver cohesive, it's collaborative, and it's the best quality of care for the surgical patient. Next slide, please. Here is an example of an ERAS team, similar to what the other speakers talked about. You can see the patient and their family, as well as all the other different types of providers. It's not all-inclusive, though. I'd like to point out a couple that are often missed when developing your ERAS team. For example, you see surgeons are included there, but oftentimes the office staff, the physicians, assistants, and nurse practitioners, they're not educated and brought into the loop. So when a surgeon understands that he's reducing opioids for a particular patient, the rest of his immediate team, they're not in the know. And then they write a pain script for something that contradicts enhanced recovery. The second example and the backbone of this team is nursing. Without education and engagement of this crucial group of providers, your ERAS program will fall over, I promise. It's a pitfall of the program, and it's a lack of education for nurses and understanding the whys and the hows of what enhanced recovery is. If a nurse doesn't understand those benefits, they may not always understand how and why to execute a particular surgeon's order, especially when it comes to administering, or more importantly, not administering narcotics. So please do not forget about the nurses. Lastly, the Enhanced Recovery Coordinator is a person that manages the program on a day-to-day level. And many programs don't start out with initially investing in these coordinators. And although they may see positive outcomes at the front, Long-term sustainability of programs diminishes because one centralized leader doesn't have their finger on the pulse. So some takeaways from your team formation. Next slide, please. So there are many functions of this team. There are things like protocol and order set development. This is where opioids are addressed in a standardized fashion. It ensures that those who are giving the narcotics, like myself as a CRNA or an anesthesiologist or a nurse, have parameters and guidelines for administration. It's the how, the when, the where, which service lines will be implemented. The ERAS team is responsible for not only clear communications between themselves, which is sometimes difficult, but most importantly, developing a system of communication and education within each individual specific group that they represent, especially the patients. The team is responsible for quality assuring the program using data. What are the rates of compliance to the protocol, and how is that used to ensure that each patient is actually receiving all the necessary interventions to improve outcomes? The data also shows that what you do is working, reducing opioids during the perioperative continuum, for example. Finally, the team needs to ensure that the program is sustainable, continuing to look at that data month after month, year after year beyond implementation, supporting the staff to continue using the protocols through education and feedback loops, and continuing to engage all members of the team and the staff and the patients to provide the best quality care over the long term. This is how an enhanced recovery multidisciplinary team will continue to reduce acute opioid use and the possibility of persistent opioid use in the perioperative patient. Now, the next video is from my friend and my colleague, Dr. Elizabeth Chareau. She's an OBGYN from New Jersey. It's a mother who received enhanced recovery for her second C-section. This is her testimony describing her experience. Please play the video.
My name is Sandra Santos. I'm 31 years old and I work in insurance. I've been working in insurance for about 7 years now. I have 2 boys. I have a 3.5-year-old and my youngest is 9 months. And I like to spend usually my weekends going out with them, doing fun stuff with them. My experiences with childbirth were completely different. So I had 2 C-sections, and the first C-section, I was in the hospital for 4 days, and it took me 2 weeks to recover. My husband had to help me with everything. The second C-section, I was out of the hospital within a day, and I felt no pain at all. With my first C-section, the pain was really intense. Even with all the opioids, I still felt pain. I wasn't able to get up by myself. I didn't think about anything when it came to the opioids. I just went along with it. It's just, I thought that's how it had to be. With the second C-section, when they mentioned to me that I wouldn't have to take any opioids, I felt that would be great. And I didn't even know I had an option. I was actually very surprised that it was nothing like the first C-section. My recovery process for the second C-section was that I didn't have to take any opioids. So I felt more awake and more able to take care of my son. And the first one, I did have opioids and I felt very sleepy all the time. I wasn't able to take care of them like I wanted to. My knowledge of the current opioid epidemic in this country is that they are very addictive and it is very hard for people to stop taking these medicines. So it was very important for me if I didn't have to, that I wouldn't have to take any opioids for my C-section. I feel it is important for surgeons and patients to discuss non-opioid options for pain because it's just a big difference with the recovery. The non-opioid option helped me recover faster so that I could take care of my older son. I was able to be out of the hospital within a day. So it was great to be able to be home and be with both of my sons. I would really encourage any mother to definitely talk to their doctor and ask them what other options are there for them.
I would also like to say thank you to all the healthcare workers who are on the call today who are actually in the front lines in this battle against COVID. I want everybody to stay safe. I'll turn it over to Dr. Renee Lev to facilitate our moderated discussion.
Thank you so much for that. As you have seen, that there's ERAS available for C-sections, orthopedic surgeries, abdominal surgeries, and even heart bypass surgery. So it really affects all the surgical specialties. I want to also thank our speakers, our experts, our nation's leaders in surgical care, safe prescribing for patients, and multimodal pain management. And here's some questions. Let me start with review of publication I did on Death Diaries, where at the time, opioid prescriptions by surgeons were the highest, and orthopedic surgeons were even higher, at 189 pills per prescription. That was at the peak of the epidemic several years ago. And how have opioid and safe prescribing changed for surgical patients, and is there more work that needs to be done?
Dr. Lev, if I might chip in here, I think in programs that use enhanced recovery protocols, prescribing practices have changed considerably. As has been seen in a number of the presentations today, we start treating anticipated post-op pain even before we start the operation with a cocktail of non-narcotic pain meds. In the operating room, again, even before an incision is made, various infusions such as lidocaine, magnesium, or ketamine can help block pain receptors even before the incision. And then, as noted, different regional blocks, either in the abdomen, in the leg, and pretty much anywhere we can operate, have also, by minimizing the pain when the patient wakes up, they have a smoother post-operative course. They need less pain medication. And a lot of work that has been done looking at prescriptions on discharge, such as by the Michigan Initiative, Dartmouth, Mayo, MD Anderson, they've looked at discharge prescriptions, how many tablets used to be prescribed, such as that number you mentioned, and how many patients actually use on average, and that has allowed them to come up with guidelines for prescribing averages to different kinds of surgery.
All right, Dr. Scott?
Yeah, I think what we're seeing is, as ERAS has rolled out across the world, is we've got more and more attendings who've adopted ERAS, and there's a profound difference between patients going through those programs and how much opioid they get, and certainly how many opioids they go home with, which is one of the key things we know for risk of addiction, and also it getting into the wrong hands in the community. And the great thing is with all these rollout programs, is we're educating more and more people, but also educating the residents coming through. So the new attendings in the last few years, they see ERAS as the standard of care, and they realize the importance of safe opioid prescribing.
This is Desiree. I would agree with both of those statements as well. Mike, taking that even further, is education of the patient. I think when patients traditionally came in for surgery, they were expecting not necessarily even just having the pain pills, but they were expecting to come out of surgery without any pain. And so that's why we just kept administering more and more and more. So that's how enhanced recovery has changed, is because we're doing much more education with not only the staff, but with the patients, and really taking time to explain to them what the comfort scale is, not the pain scale. And that they are having surgery and they're going to have some tolerable pain, and that we are there to support them. So I think the more work that needs to be done is continue to push education out into the communities and not just keep it to ourselves in the hospital.
Thank you for that, and we definitely like that better. What is your comfortable scale instead of what is your pain scale? ONDCP has a safe prescribing working group that is drawing attention on the issue of concurrent prescriptions by different physicians and various CNS depressant medications. And we know that most people who have unintentional overdoses of medications die of a combination of these depressant medications, not a single medication. How are surgeons, anesthesiologists, nurses, and hospital systems addressing the issue of concurrent medications? Dr. Scott.
Yeah, I think this is a big challenge because it's a new resource that we need to actually address this. So the key thing is you need to identify patients early before they actually come for surgery, so in the surgeon's office. And this is where pre-assessment clinics can also be very useful, because we can then identify not just if patients are on opioids, but also if they're on other addictive medications like benzodiazepines, which can cause other interruptive problems. We do know that patients who have opioid tolerance have increased risk of complications, increased length of hospital stay, and also about a 15% readmission rate. So it actually pays for the health system to screen for these patients and get them sorted before they come for their surgery. And we do know that if you can reduce the amount of opioid people are on, it doesn't mean to say you have to get them off completely, but even reducing the amount of opioids they're on by 50% can actually lead to improved outcomes. So I think the key thing is to have a strategy to screen and address the patient's issue, and whether that's going back to their primary care physician, whether it's going to a specialised clinic, or we have a pain service clinic that can do this. But I know, for instance, that Steve Cates has actually engaged patients himself and actually managed to wean patients just by engaging them. And I think it does depend on the patient and what the reason they're on their opioids. So, Steve, do you want to comment on that? Because you've had some good results, I know.
Yeah, it's very much what you've said. We speak with the patient. We explain that the use of the opioid medications to treat things like arthritis and other issues are not the best way to treat them, and that we need to get the medicine stopped prior to the surgery. And we work with the patient to do that. And then to make sure that they are giving us accurate information, we will do blood tests to make sure that they have actually stopped using the medicine. And we also will engage their primary care doctor if the primary care doctor can be helpful. Some of the docs want to be involved, some of them do not. We actually have had some of the primary care doctors tell the patients that we're going to prescribe all their medicines as soon as they come to our office. And yeah, that requires a long discussion with the patient. It takes quite a bit of time. Sometimes the patients do get upset, and some of them will leave our care. But it's important to have a strong discussion with the patient to explain that this is harmful for them to continue the medicine, and that after surgery they'll have even more pain than they had beforehand, at least for some period of time, and that they would be susceptible to having a drug overdose event. So it's important to get them off the medicine pre-op, and we find that they will wean off the medicine quickly post-operatively if we've gotten them off pre-op. If you don't stop the medicine pre-op, they continue it, and even if you fix the painful problem like a bad knee or a bad hip, 1 year later they're still taking the opioids. And this is how people get into trouble, as Director Carroll had explained earlier, and it's absolutely true.
Well, thank you. I've seen as part of ERAS, there are places who have special clinics preoperatively for the higher-risk population who are on multiple medications and need to have that coordinated before surgery, and also postoperatively, especially with the elderly population, avoiding benzodiazepines and delirium and other such complications as well. I'd like to have a final question here to each of you. What is the future of enhanced recovery after surgery and safe prescribing in surgical patients? And each of you will give a different perspective. Dr. Young-Sidok, what about ERAS USA? What's the organizational perspective for the future?
Thanks, Dr. Lebs. ERAS USA is thoroughly committed to continuing research, education, training, and implementation of evidence-based medicine, as you've seen, so we really optimize our patients' recovery after surgery. Chose to, as a society, to emphasize multimodal pain management precisely because we could see a different pattern of post-operative narcotic use and prescribing in the U.S. compared with Europe. And we've partnered with other entities to provide grants for implementation programs, which we run. We will continue to train, teach, and coach others who want to do that. And other surgical and medical societies have complementary initiatives. For example, AHRQ, as Dr. Liza Wick mentioned, and the National Laparoscopic Society, SAGES, which has its own task force and an upcoming Opioid website. Thank you again.
Dr. Scott, what about the international perspective?
Yeah, I think it's very exciting. I think everyone can gather from my voice that I'm from the UK, and I came over really as part of the group to introduce ERAS across here in the USA. Just been down in Virginia and now in Pennsylvania. And I've been involved in the implementation of ERAS across many countries, every continent, over a dozen countries. And it's really become a standard of care in now many countries all around the world, because there's not many things out there that really give you a reduction in complications, improved recovery, and also all for reduced costs. So it really is value-based healthcare. And the reduction in opioids is also a key thing. And I think we should be aware that it isn't just the US that has an opioid problem. We're seeing more of a problem in the UK and other European countries. So they are following the US. So I think ERAS as a whole has a huge amount to offer the whole world and the whole surgical community to improve recovery and reduce complications for that, to reduce the opioid addiction problem.
Thanks. And Dr. Eliza Wick, what about the hospital perspective? Dr. Wick. Dr. Steve Cates, what about the surgeon's perspective?
From a surgeon's perspective, I think the enhanced recovery after surgery is probably one of the greatest things to hit orthopedic surgery. What we see is we see a way where we can really help the patient recover faster with less pain, which is really what the patient cares about. Our patients care to get better faster, to get back to work, to get back to their life faster. And I think this offers an opportunity from my perspective for us to be better physicians so that we can provide good advice to support the efforts being carried out by the primary care physicians to manage their diabetes, lose weight, and stop their opioids. These are really important things that we can do to improve the patient's life, and which is why we went into medicine.
Thank you. Let's see if Dr. Wick is back with us. No? All right. So finally, Desiree, what about the patient's perspective?
Yeah, so the future of enhanced recovery and safe prescribing for the patient is so much about becoming an active and engaged participant in their own care and really educating themselves with everything that's out there through the different societies and all the information that they can gain to improve their own outcomes. I think the other thing is that patients through enhanced recovery become more informed consumers of their own health care, and I think that's where this is going for them.
Great. Thank you so much. Next slide, please. I want to thank our experts and participants in this it's very heartwarming to see engagement in safe prescribing and enhanced recovery after surgery. And this concludes our question and answer session of the webinar. The take-home message and summary I hope we received from the webinar are: number one, enhanced recovery after surgery involves 3 pillars: pain management that minimizes opioids, fluid management, and early mobility. And this is applicable to every type of surgery. Number 2, a multidisciplinary approach is key to ERAS principles and safe prescribing. Number 3, safe prescribing in surgery involves minimizing opioids, benzodiazepines, CNN depressants, and the coordination of medication. And finally, addiction medicine is involved in all health care and for all medical specialties. Next slide. I'd like to remind our listeners that most of the information presented today can be found on the ERAS USA website, erasusa.org. And I want to thank everyone for all your work that you do every day in saving lives in the operating room, in the hospital, with surgical patients, and patients who suffer from addiction. Next slide. The pandemic is a war with an invisible enemy. We're all facing that, and the healthcare professionals are on the front lines and our heroes and most precious asset. You are risking your lives, your health, and the health of your family for the greater calling of medicine and helping others. I bless you with health and salute you. And this concludes today's webinar.